Hello, I'm Kathleen Hwang, and I'm an assistant professor of urology and pathology and laboratory medicine at Brown University. I'm going to be giving a brief update about testosterone supplementation and its impact on fertility. The Endocrine Society defines hypogonadism as a clinical syndrome that results from failure of the testis to produce physiological levels of testosterone and the normal number of spermatozoa caused by the disruption of one or more levels of the hypothalamic pituitary and testicular axis. The impact of testosterone is fairly broad. Outside of the male sexual organs, it has impacts on many different organ systems, including the skin, the brain, the liver, muscle, the male sexual organs, kidney, bone, and even the bone marrow. So it's pretty straightforward that with alterations of testosterone ranges and levels, many different organ systems can be impacted, suggesting some of these symptoms that patients complain about. This here is a representation of what is the crucial communication between the upper higher centers of the brain and the testis itself. The testicle basically does two things. It produces testosterone as well as producing sperm. So we have the hypothalamus at the upper top of the higher center, which pulsatile secretes GnRH. That in itself will stimulate the anterior pituitary, which then will release both FSH and LH. FSH targets the spermatogenesis and stimulates sperm production. LH, however, will target the Leydig cell population and stimulate testosterone production. Both of these productions will then have a negative feedback, which will then communicate back to the upper centers in the anterior pituitary, as well as the hypothalamus to maintain balance. Symptoms of hypogonadism are in fact not unique nor specific. Screening with testosterone levels is very appropriate when presented with these symptoms. A diagnosis of hypogonadism can only be made when you have one or more symptoms in combination with low testosterone concentration. Based on the 2010 Endocrine Society guidelines, here's a general consensus. For diagnosis, really should be targeted in only with men with consistent signs and unequivocally low serum testosterone levels. We should not be screening the general population. However, you should consider measurement in disease conditions where there's a high prevalence. For accurate measurement, morning testosterone levels are the most accurate. You want to confirm abnormal levels and, if in question, potentially assess free and or bioavailable testosterone levels. Our treatment goals are to induce and maintain secondary sex characteristics as well as sexual function. Overall, you also want to improve sense of well-being, in particular focusing on muscle mass strength and bone mineral density as well. But there are also instances where you don't treat. There are specific instances such as patients with active breast and or prostate cancer, a patient with a palpable prostate nodule or induration on exam, someone with an abnormal PSA, patients with known chronic erythrocytosis, untreated severe sleep apnea, who have severe lower urinary tract symptoms, and uncontrolled or poorly controlled heart failure. Testosterone replacement therapy can come in many different formulations, and there are specific adverse effects that we need to be aware of. Oral tablets have an impact on the liver and should follow cholesterol levels. Intramuscular injections may have an impact on fluctuation in mood or libido, complaints of pain at the injection site, and higher excessive levels of erythrocytosis, particularly in older patients. The transdermal patches often will have complaints about skin reactions at the application site of the patch. Subsequently, transdermal gel application, counseling with patients needs to be taken where there's potential risk for testosterone transference to a potential partner. Lastly, we have also pellet implants, and with this small procedure, there are risks for infection as well as expulsion of these pellets. Our treatment goals, however, are the same regardless of how they receive the exogenous testosterone. We want to manage expectations by partnering with the patient with extensive counseling. We want to match appropriate treatment to the individualized patient depending upon where they are in life. And we want to titrate and increase blood testosterone levels to the normal eugonadal range and avoid supraphysiological peaks. And our ultimate goal is to ameliorate and or cure the symptoms which they originally presented with. The most important part about testosterone replacement therapy is counseling. Like testosterone with any other medication, there are known side effects and complications. While this is a very large table with lots of them, we particularly will focus on the risks for erythrocytosis, focus on risks of cardiovascular disease, as well as testicular atrophy and or infertility. Testosterone supplementation, regardless of how it's given in any form, leads to atrophy of germinal epithelium in normal men, and this goes back to that hypothalamic pituitary gonadal axis. It suppresses spermatogenesis and may lead to azoospermia in as fast as 10 weeks of treatment. And sperm concentrations, while they usually may rebound to pre-treatment levels within 18 months, up to 4 to 10% of men, particularly who have had impaired spermatogenesis prior to start of treatment, may remain azoospermic. This, in fact, has a huge impact on their future paternity, and this is why it's such an important point for consultation prior to starting testosterone supplementation. To conclude, successful treatment of hypogonadism depends upon disease awareness, understanding the limitations of what treatment can achieve, establishing realistic expectations with the patient with absolute crucial counseling, and discussing all the options as well as the adverse effects.